some of the things that may be found in those machines obviously are going to be naloxone with or without kits. And when I say kit, a kit has all of the information that comes with that naloxone box. And it may come with gloves and a mouthpiece for rescue breathing and all of the little things that you would need to save a life.
Hello, and thank you for listening to the HOCO Health Podcast, a podcast where we discuss all things public health. I'm Howard County Health Officer Dr. Maura Rossman. During today's episode, we're focusing on overdose prevention and harm reduction. Despite some great strides, the overdose crisis continues to touch families, neighborhoods, and workplaces in our county. But through collaborative action and community-driven strategies, we're working to prevent both non-fatal and fatal overdoses. We'll take you behind the scenes of several of our current overdose prevention efforts, from targeted public service campaigns that raise awareness and naloxone training that equips community members with the tools to reverse overdoses. We'll also highlight the critical role of harm reduction efforts like syringe services, which reduce the risk of infectious diseases, to fentanyl test strips. You'll hear how peer support specialists, individuals with lived experience, are embedded with our partners to provide real-time outreach and connection to services. And we'll share exciting plans for the installation of naloxone and harm reduction materials vending machines, making life-saving tools more accessible than ever. Let's talk to the public health professionals working every day to turn harm reduction into hope. Our first guest is Dylan McManus, the manager of the Harm Reduction Program. Dylan, thank you for joining us, and tell us a little bit about yourself.
Thanks so much, Dr. Rossman. Pleasure to be here. So, as you said, I'm the manager supervisor for the Harm Reduction and Peer Recovery Supports Unit here at the Howard County Health Department. I've been here for 2.5 years. I've been involved in harm reduction for almost 10 years now, starting as a volunteer, mostly starting at Prevention Point, Pittsburgh, where I first really learned about it after helping a number of friends deal with their own substance use crises. A few died, a few haven't. Some went to treatment, others returned to use. It's a whole wide range of outcomes, but I started there. I moved back here to Baltimore. I was volunteering with Baltimore Harm Reduction Coalition. I've volunteered with Spark in Pigtown, and I've always wanted to work more properly in harm reduction. This came up, and a former supervisor sent me the link and said, you were always trying to shoehorn this into what we were doing, so maybe you'd be good at this. So I applied, and here I am.
We're so glad and delighted that you bring your passion to Howard County. I'm sorry to hear about your friends, but we're all here because we all have family, friends, acquaintances who have been touched by substance misuse, and in particular, the opioid epidemic that we're talking about today, and strategies to save lives. It's always my hope that we can prevent substance misuse, and for those that are using, get them to quit. But that's a long process and not always possible. So in between then, I certainly have come to appreciate harm reduction strategies to keep our loved ones, friends, colleagues alive with the hope of managing their addiction and hopefully overcoming it. So Dylan, can you walk us through how your team is using certain tools like peer support, syringe services, fentanyl strips, the harm reduction strategies that you mentioned to help prevent overdoses and support our friends in the community?
Yeah, the whole suite of options for sure. So our program, Harm Reduction and Peer Support, uses exclusively peer recovery specialists for all of our services. So it's bifurcated, kind of. So we have our syringe service program, which I think for those who are in public health for a long time know them as needle exchanges. We just changed the term. Some of the modalities in which they operate and some of the best practices change over time. And so there isn't like a one-to-one exchange of a needle necessarily. It's more of a open service provision. It's needs-based. That's following best practice and the evidence base. And there's peer support that may not necessarily be syringe services, but could incorporate a lot of different things like more formal treatment connections, just coaching someone through situations that they may be experiencing throughout their course of their own substance use. It could be mental health also. A lot of our peers have experience in that and training in that. Different types of benefits, connections, referring people to DSS, or even just inside here at the health department for different types of sexual reproductive services, for Medicaid, the ACCU, all of this sort of in-house kind of stuff that we have here that people can utilize. So within our harm reduction program, more formally, we have a syringe service program, which is people who inject drugs can come get clean supplies. So needles, hookers, cottons, everything you might need to inject drugs. And why we do that primarily as a public health function is to prevent the spread of HIV and hepatitis C, which is how they initially became more publicly funded in the United States. We're doing a pretty good job on that, as far as I can tell. I keep track of historical rates of Hep C, HIV, and it seems pretty stable, which tells me that for the purposes of our SSP, it's working pretty well. SSPs also, as you can find in research, tend to have greater uptake in things like benefits, other community resources, treatment uptake and retention. And we see that in our program as well. Over the course of a few years, from 2022 to 2024, we've had about a 421% increase in program signups, which is pretty astronomical for being really operational in a pretty short amount of time. I think it started in earnest in 2019, so that amount of growth is really amazing. So we have those sort of basic core services of harm reduction. We also do condoms. We do smoking, snorting supplies for people who might not inject, but also use drugs in a different way. So we can engage sort of a drug user community in a more holistic kind of way. There are some instances of hepatitis being spread through shared smoking supplies. There's a higher disease burden of individuals with Hep C who share snorting supplies. It's unsure whether it's really transmitted through the supplies or not, but we know there's a higher prevalence of Hep C among that particular use population. So it's good that we have the kind of clean tools. We provide education on safer use modalities to try and mitigate any adverse effects. We also do naloxone distribution. I say we use here two different types of strategies. Our strategy in harm reduction is targeting naloxone distribution to a high-risk population, which is just getting the naloxone into the hands of people who use drugs who are most likely to experience an overdose. The other model, which we'll hear about later, was community saturation, getting it as accessible into as many hands as possible. And I think we've done that fairly successfully. As you mentioned, we also have fentanyl test strips, so people can test whatever drug they have for fentanyl. We also have xylazine test strips, which is xylazine is a drug additive, a veterinary sedative that we've seen in the drug supply, not approved for human consumption. It causes more serious, pervasive wounds to extremities that can be really difficult to treat without sort of more formal clinical treatment, which is hard for a lot of people to get to and access. We also participate in the state's drug checking program. It's called RAD. So we are able to take supplies that people return to us. We swab them. We send them off to the National Institutes of Standard and Technology Lab, which is a federal agency, and they send back to us the different types of substances that might be found in any given sample. And we see a lot that people don't ask for.
That's amazing. So essentially, we're trying to prevent further harm to individuals who are using drugs. Anything from infectious diseases, you mentioned hepatitis C, HIV, which one can get from sharing needles and then transmit to others who may not be using, to you mentioned wounds, obviously overdoses and death. So a variety of different adverse outcomes related to the drug use we're trying to mitigate by harm reduction services. And it's amazing, the 400% or so increase that you mentioned means that you're meeting a need. And there are people out there because some of these, can be hidden. And in other podcasts, we've talked about the stigma of mental health. There is a stigma of substance misuse that families, even though we're all touched by it, we may not talk about it.
Sure. I think that's why it's so useful to have peers. It's not an individual on the street who might be using this or that kind of drug coming to me or sort of a professionalized public health staffer. It's someone who they can come up to and say, hey, I'm injecting dope and it burns really badly. And here's kind of what's going on. And they can just have a practical conversation with someone who's been there and had that kind of experience and just have a very real, practical, helpful conversation about what's happening. It doesn't need to be hidden. You don't need to really veil anything. You can talk straight and be open. My background is social work. So we know that when you are able to build rapport really well, quickly, and have trust, people are better able to hear you and you're able to exchange information. People are more likely to listen and consider doing things a bit differently, which is exactly what peers do with individuals every day. They just build rapport, build trust, you build a relationship, and you're better able to connect with people and they're more likely to utilize the resources that you provide, that being the case.
Yes. Peer support specialists play a big role in your program. And you've just described how people with lived experience are helping others and how they're making that difference. And we pride ourselves, right, in trying to meet people where they are, not necessarily where we are. And I see the peers as having the expertise and experiences that I lack, someone who is not a drug user. So it's really critical and I think making a big difference. Dylan, can you describe, because we have our peers everywhere in Howard County, where are our peers embedded?
So, where aren't they embedded? So the hospital and the ED is one. On our own of Howard County, we have peers go in there. It's a drop-in center, not too far from the health department. It's a recovery and wellness-oriented drop-in center. It's peer-led, mostly by mental health peers or people with their own kind of lived experience. It's really great. We will soon be based in the library system, the detention center. We help run groups. We are based in the schools currently. We have peers who work with students in the public school system. We have a peer in drug court. They've been there for a while. That's gone really well.
Leola Dorsey.
Thank you. We have peers at the Leola Dorsey Day Resource Center in Jessup. It's a homeless drop-in center. We're there twice a week. That's a great partnership, particularly. So we take our syringe services van there Mondays and Wednesdays, and we park in the auxiliary parking lot just up the street for anyone who needs to pick up supplies and doesn't necessarily want to do so in the actual center, sort of in the midst of a lot of people. It's a little more low key. Also, plenty of people do pick up supplies in the center. So we try to service different needs and different wants in different ways. We also have a table inside that we do general resource provision, linkage to treatment, linkage to benefits and other resources. We also currently have a partnership with the homeless services system. We have a peer who does homeless outreach. We also do street level outreach. On Fridays, we do a lot of hotel outreach to individuals in short-term hotel stays, sometimes maybe long-term hotel stays. But we notice that we have a lot of individuals who utilize our services up and down Route 1 specifically. And so we service a lot of folks that might be transient, sex workers. We recently developed a partnership internally with reproductive health to do self-collected STI testing. We've had an uptick on that pretty recently, which has been really useful. Yeah, so we're a little bit of everywhere.
I liked your statement. Where are they not? As I keep saying over and over again, if you're out there and you're using or you're affected by someone using, you're not alone. Substance misuse affects virtually every family, and hence why peers and our services, we're trying to be everywhere. We're accessible in different modalities so people can get the help that they need. So Dylan, we're going to wrap up a little bit with you, but can you tell us what you're most excited about when it comes to the future of harm reduction in our area, like new ideas, partnerships, or ways to reach even more people?
Sure. So I'm excited about an upcoming partnership with the library system. So they have a lot of different populations that we've not necessarily had a lot of contact with. So they service a larger immigrant population, young and pregnant parents who might be teens or young adults. They have early childhood education classes. They had said that we might be able to plug into younger students, maybe that are in and out of schools that maybe we haven't had much contact with. They have a lot of teen and youth types of programming. I think that will be really cool for us. We're planning to be in every library in the county to cycle through on a monthly basis. So that'll give us a really wide range of access. We don't really have much presence right now as far as more rural or more sort of outside of Columbia, outside of Elk Ridge, Jessup kind of area. So I think that'll be really great for us. I think especially trying to expand a little bit into the western part of Howard County, I think is really interesting. I think we do a really good job in the more central locations, just because there's just a lot of resources that are concentrated here because there's a lot of people. But we know that there are people in western Howard County who live more rurally who could also use services. They often use services in Frederick because it's closer than they are to here. But I think it would be really cool if we were able to connect with them a little bit better to serve a little bit of a different geographic population. So those are some things that I'm looking forward to. I'm also looking forward to the vending machines. I think those will be really cool, which I think you're going to talk to someone else a little bit about.
Absolutely. Well, I'm looking forward to the partnership with the library system as well and hearing more about the vending machines shortly. We're going to take a quick break right now and be back to talk with our next guest, Mary Lacasse. Welcome back, and thank you for listening to the HOCO Health Podcast, where we talk about all things public health. Today, we are talking about overdose prevention with guests from our Bureau of Behavioral Health. Joining us now is Mary Lacasse, who is the administrator of our Overdose Response Program. Thank you for joining us, Mary, and can you tell us a little bit about yourself?
Certainly. Thank you, Dr. Rossman, for having me here today. I'm Mary Lacasse, and I do oversee the program that does naloxone training, education, and prevention programming for overdose, as well as physician and pharmacy outreach for medication-assisted treatment. We developed a substance use dashboard, a map of overdose risk that really assists us in focusing on areas of the county most at risk for overdose and overdose death. That's a few things that I do.
Awesome. And you and your team also provide lots of data so that we can make informed decisions among the health department and our partners. My first question, Mary, goes back to something that Dylan talked a little bit about, naloxone. Your team provides naloxone training across the community, from everyday residents to local businesses. For those who might not know what naloxone is and why it is important to have it available, can you tell us a little bit about naloxone and what it does?
I can, certainly. So naloxone, and I'm going to get into the definition, but it's only effective in reversing an opiate overdose. Opioids are a class of drugs that relieve pain. And what makes opioid medications effective for treating pain can also make them dangerous. So naloxone and Narcan, which people also may hear, are often used interchangeably. And the difference? Naloxone's the generic name of the drug. Narcan's the brand name. Think Kleenex versus tissue. What is naloxone? It's a nasal spray. It reverses an opioid overdose. It's safe for the elderly, for pregnant individuals, for children, and even for pets. Yep, pets. It wears off, though, in 30 to 90 minutes. So folks still may need medical attention. So even when individuals use naloxone or Narcan, they have to call 911.
Yes, naloxone saves lives. And we also encourage providers. You mentioned naloxone reverses potential effects of an overdose from pain medication. So it's not unusual for prescribers when they prescribe an opioid drug for pain to also prescribe naloxone, because the drug can get into someone else's, a child, a pet you mentioned. Yep. And you would want to reverse that as soon as possible to prevent death, because opioid overdoses cause people to die. Not only do you provide the Narcan or naloxone, but you have led in-person naloxone training sessions, because we want people to know how to use it and when to use it appropriately. What kind of reactions or questions do you usually get from participants? Are people surprised how easy it is to use?
We do get several kinds of reactions, and the easiest way to answer your question is yes. People are very surprised that it's that easy to use. When we do a training, and we do a group training or a larger training, it's often, as you mentioned, we love our data, right? So it's often full of little sound bites, a little bit of data about our county, a little bit of data about Maryland and where we compare, even looking at medications that are prescribed by physicians and what's real and what's fake that may be out on the street that isn't an actual prescription medication. And people are very surprised about all of these things. Their kid takes Adderall and they go to college and they ran out of their medication and their friend's like, oh, I have some Adderall here, you can have mine. But was it prescribed? And you should only take medication, of course, that's prescribed by your physician for you. People are very surprised at how easy naloxone is to use, how easy it is to carry and transport, and how easy it is to access it, because here we offer it for free. It's available over the counter now in pharmacies, so people can just walk up and they don't need a prescription. They can just say, hey, I need some, so they can keep that with them.
Now, you mentioned, or we were talking about in-person training. You said you do group trainings, but you also have an on-demand virtual training for anyone interested in learning how to use naloxone. How does that work? And how simple is it to get someone to get trained?
Great question. I think that the online training, the most fun part of it actually was designing it, because the devil is in the details of designing anything. And we wanted to make it easy enough to use and understandable enough for folks, but yet still educational and supportive. So this is a very simple online training that I can even offer you the QR code or the link for folks who are listening to the podcast and may be able to access that later. People can go right on to that link or use that QR code, and it takes them to a very short, we call it the survey. It's something the state has to collect data. You said we like our data, but it's something we have to do. And then we also give people a little quiz, kind of to find out what they knew ahead of time. And then they watch a very short video, and then they take the test, the quiz afterwards, same questions that they got before. And then they literally have learned the training. It takes less than 5 minutes, and then they can stop by the health department when it is convenient for them and pick up their naloxone kit.
Thanks. I want to go back to something you said, Marian. Maybe either you or Dylan can comment. So you talked about naloxone, how it reverses the effects of opioids. And I mentioned prescribed opioids. And then you mentioned also, but people may be using drugs that aren't prescribed, that they've gotten from someone else on the street, that may be laced with something unintentional or intentional. And we've all heard about fentanyl. And fentanyl is a quite powerful opioid that particularly can cause overdoses. So I don't want people to forget that. I don't know if either of you have a comment on fentanyl and the drug supply and why Narcan is helpful, particularly in that case.
Well, I'll start. And then Dylan, if you want to jump in, absolutely, please feel free to jump in. Dylan did talk about the RAD data, the rapid assessment of drug data that he gets from the state. And much of our supply of drugs that people think they're getting aren't exactly what they're getting. And there's a very high percentage of fentanyl found in all of our street drugs. These are not drugs prescribed by a physician, but these are the drugs we're talking about that are found on the street. And fentanyl is so much more dangerous than any typical opiate. I mean, even if you look at heroin, the amount of heroin versus the amount of fentanyl you would need for the same effect, it's grains of salt we're talking about, such a small amount. And people can much more easily overdose with fentanyl. Dylan, anything you want to add, share?
Yeah. So as Mary said, we have a widely mixed drug supply. So often when someone wants to buy fentanyl, they will get fentanyl, but they'll also get things that they didn't ask for. So it could be just filler. So something like quinine or ibuprofen or Tylenol, tramadol, a bunch of other stuff that will just make what they bought look like it's more than what it is. Other things that can be added like xylazine or maybe a benzodiazepine can adulterate the effects of what they buy to cause something a little bit different. So maybe more sedative effects or something else similar to that. And so often when you go to buy your supply, that's why we do drug testing, is to try to do some confirmatory stuff for people on the street that they're not able to do otherwise. And so we can give them the best advice possible if and when they choose to use that particular drug. They can know what's going into their body, they can know what the potential effects are, and they can know different types of ways, if possible, to mitigate and keep themselves as safe as possible.
Thanks for explaining that. Back to Mary. Your program has also partnered with places like gas stations and hotels, I think Dylan mentioned that earlier, to share naloxone resources. Why are these types of locations important in the fight against overdoses?
I think Dylan may have said this as well, because it's the places where people are. We want to be present where people are, not off the beaten path where people don't travel, but we need to be available to people where available, work and live. Here's some examples. Recently, we've been doing, I did mention those group trainings. We trained all of the Meriwether Post summer staff. That was over 175 people that we trained in one day on their stage. We'll probably never be on their stage again, but it was quite the adventure. And all of their staff now know how to administer naloxone in case there is an overdose there at Meriwether. We have just made a relationship with the Columbia Cab Company, and we're going to be training all of their staff in June, because cabs, again, transport lots of people. And why not give them the available tools in case one of those people does have an overdose? We even trained, Dylan was talking also about their library system relationship. And Dylan and I often do very parallel work, but we oftentimes braid our work together. And we had originally trained the entire library system in how to administer naloxone, from their staff and cleaning crew all the way to the individuals that work every day in that library with the consumers that use the books. So we're really trying to be out there everywhere people would be, so that they maybe get a more normalized view of the fact that it may not be them. Because sometimes you'll approach someone in an event that we're doing and we have a table at an event and we're like, hey, come on and learn about naloxone training. People are like, oh, I don't have a drug problem. That's not for me. I don't need this. But we're like, it may not be about you, but it may be about what happens if you go to McDonald's to get a burger and someone has overdosed in the parking lot. Oh, I never thought of that. What happens if you're out and about and you're in the grocery store? So people are often being assisted maybe in thinking of other ways that they may encounter something, and basically how to save a life.
That is really awesome. This is such a great discussion, but I do want to get to Mary 2 more strategies that your team is working on. One is the vending machines that both you and Dylan mentioned, and the other is the public service campaign focus on safe medication storage. Can you, in a minute or two, just tell us briefly about those 2 things?
Sure. So I can tell you a little bit about our vending machine plan. We plan on piloting one outdoor machine at the Loyola Dorsey Center. We plan on piloting 4 indoor machines. We've surveyed the community to find out the best placement of those machines, but we will be having those machines sort of seeing how they're utilized. Are they able to support the community the way the community wanted? Some of the things that may be found in those machines, obviously, are going to be naloxone with or without kits. And when I say kit, a kit has all of the information that comes with that naloxone box. And it may come with gloves and a mouthpiece for rescue breathing and all of the little things that you would need to save a life. May have fentanyl test strips in it. We may also, in those machines, have some xylazine test strips, condoms. We may even have some feminine hygiene products or first aid like bandages. And you also talked a little bit about our medication safety and storage. Do you want me to move on to that next?
Yes, if you can just tell us a little about that and where people may be able to get some free items.
Absolutely. So I think one of the most amusing parts of this whole medication safety, and it's a funny, not funny, is that medication safety is, everyone knows how to be safe. Oh, well, if I'm not using this medication, I'll throw it away. But one of the things that I think is most dangerous, actually, is throwing your medication in the trash can or flushing it down the toilet. So a lot of our education is spent very simply on directing people how to safely dispose of their medication. There are 4 drop box locations in our county at police stations, at the Northern Police District, the Southern District, the Gary Arthur Community Center, and the Community Outreach Building on Little Patuxent Parkway. They have drop boxes where people can drop their medication off and not have to throw them away. We have something called doTERRA bags, and those doTERRA bags are where they're carbon-based. You put the medication in, you add a little bit of water, you shake it up, and it neutralizes the medication, so it is safe to throw it in the trash can. We also teach people a little bit more about not sharing medications, keeping them out of the reach of others, and locking them up.
This is great information. Let's take a quick break and we'll come right back for a quick wrap up. So as we wrap up today's conversation, and what a great, robust conversation we've had, what would you say to someone listening who wants to get involved, whether it's getting trained in naloxone use, assessing harm reduction resources like fentanyl test strips or syringes, or connecting with a peer support specialist? Where can they start and how can they reach out to your programs? We'll take Dylan first.
Sure. Well, you can reach us here at the Health Department Tuesdays and Thursdays from 10 to 3. Our harm reduction van is outside in the parking lot. If you're looking at the main entrance of the Health Department, look to the left, and we are the lone van in the front of the parking lot. We also have a peer line or a harm reduction line that you can call to talk to a peer about either. Or if you just have any basic questions about services, you can feel free to call us there too.
And Mary, where can people find your team services?
Well, we're around all the time. Oftentimes people just go online and request trainings from us, but they could also call us at 410-313-6202 and ask for me, ask for Toyin, or any one of our staff, and we would be glad to assist them in learning about naloxone.
Awesome. Thank you both. Unfortunately, we have run out of time today. I want to thank our guests, Dylan McManus and Mary Lacasse. You can stay up to date on what's going on at the Health Department by following us on social media at HOCO Health. And you can also listen to all of our episodes of HOCO Health podcasts at hocohealth.podbean.com on Spotify or wherever you listen to your podcasts. We hope you will join us again next time for a new public health topic.
Thank you for listening to Dragon Podcasts. You can find this show and all Howard Community College podcasts on most streaming platforms, as well as our host platform, Podbean. at podbean.com/dragonpodcasts. That's podbean.com/dragonpodcasts. And as always, we appreciate you tuning in.